Hello friends, welcome back to Dental Info. Today's topic is a continuation of jaw relation in complete dentures part 2, which is a very important step during the fabrication of a complete denture. So let's get started. Before we start, make sure you subscribe to the channel and click on the bell icon to receive a notification when we release a new video. In our previous video, we have already studied which are the different types of jaw relations. If you haven't watched the video, do watch it. Link will pop up on the I button above. So, coming to the types of jaw relations, first is the orientation jaw relation, then the vertical jaw relation, and third is the horizontal jaw relation. Today we will discuss the vertical jaw relation in detail. So let's start with the topic of vertical jaw relation. The vertical jaw relation is defined as the length of the face as determined by the amount of separation of the jaws under specified conditions. The amount of separation is generally determined by using two anatomical landmarks, including the tip of the nose and the tip of the chin. The vertical dimension can be classified into two types. First is the vertical dimension at rest, and second is vertical dimension of occlusion. This diagram will help us understand what is vertical dimension at rest and what is vertical dimension of occlusion. Here in this diagram, OVD is the vertical dimension of occlusion. Vertical dimension of occlusion is the length of the face when the teeth are in contact in maximal intercuspal position. The stop can be in the form of teeth or occlusal rims or center bearing point or any other stop. And here this determines the RVD, which is the vertical dimension at rest. Vertical dimension at rest is the length of the face when the mandible is in rest position. Mandible in rest position means that the muscles are in the state of tonic equilibration. The difference between the vertical dimension of rest and the vertical dimension of occlusion is what is known as the freeway space. Now let's understand the freeway space in detail. Here in this diagram, we can see that the stops, which are the teeth in this case, are in contact. So the length of the face determines the vertical dimension of occlusion. And in this diagram, we can see the mandible at rest with a free space present between the stops, indicating the vertical dimension at rest. This free space seen between the stops is nothing but the freeway space. The freeway space ranges between 2 to 4 mm. Coming to the factors affecting vertical dimension, there are various factors affecting vertical dimension. First is gravity. The downward pull has an effect on the vertical dimension while it is being recorded. The other factor is the neuromuscular disturbance. It will be difficult to determine the rest position in patients with such problems. The dentist should be more considerate with the patient and spend more time to determine the rest position in such patients. The next factor is relaxed position. When a patient is nervous, tensed, irritable, or tired, the rest position may be inaccurately recorded. It should be determined when the patient is relaxed. The next factor is duration. As the vertical dimension at rest is a position in space, the patient cannot maintain the rest position for long periods. The dentist should make the measurement without any delay. It is very important to take these factors into consideration while recording the vertical relation. Any errors in recording, such as an increase or decrease in the dimensions, can have ill effects. So now let's discuss why the vertical relation is important and why it should be recorded. First, let's discuss the effect of increased vertical dimension. First is discomfort. Increasing the vertical dimension alters the environment in which the swallowing takes place, and until the original position is restored, the discomfort will persist. The effect of teeth coming in contact sooner than expected causes discomfort. Second is trauma. The sudden and frequent contacting of teeth causes trauma to the denture-bearing area, especially under the lower denture. Correcting the fitting surface of the denture will typically not solve the problem. Third is TMJ problem. The constant tooth contact will also affect the TMJ, causing soreness and pain. Next is bone resorption. The increased vertical height does not allow the muscles that close the mouth to complete their contraction. This results in continuous force on the underlying tissues and will result in its resorption. The next effect is muscular fatigue. Due to the constant effort of the muscles to close the mouth, muscular fatigue will also occur. Next is clicking of teeth. The premature contact of teeth sooner than what the individual is used to will cause clicking of teeth. Next is facial distortion. The early contact of teeth will lead to an inability to close the lips, which will produce a strained expression and elongation of face. Next is difficulty in swallowing and speech. The inability to close the jaws correctly will cause difficulty in swallowing and speech. Now let's discuss the effect of decreased vertical dimension. First is inefficiency. The biting force exerted by the teeth in occlusion decreases, which causes inefficient mastication. Second is cheek biting. The loss of muscle tone and reduced vertical height causes the flabby cheeks to become trapped during mastication. Third is TMJ problem. The patient has to often protrude the mandible to occlude the teeth, and this causes pain and clicking in the TMJ. Next is facial distortion. Decreased vertical dimension has effects like nose appearing closer to the chin, loss of lip fullness, loss of tonicity of muscles of facial expression, face appears flabby, and patient appears older. Next defect is angular cheilitis. The corners of the mouth form deep folds which are bathed in saliva. These folds become infected and sore. In order to avoid these effects of increase or decrease, the vertical relation should be correctly recorded. There are various methods for correctly recording the vertical dimension. These include mechanical methods which include ridge relation, measurement of former dentures, and pre-extraction records. And the physiological methods include physiologic rest position, phonetics, aesthetics, swallowing threshold, and tactile sense. Now let's discuss each method in detail. Let's begin with mechanical methods. The first method of determining the vertical dimension is through ridge relation. The distance between the incisive papilla and mandibular incisors act as a guide in determining the vertical dimension of occlusion. The incisive papilla is a stable landmark. The distance between the incisive papilla and the edges of the mandibular anterior teeth is 4 mm, and the distance between the incisive papilla and the edges of the maxillary anterior teeth is 6 mm. These measurements may, however, vary, and this rule is not relevant to patients showing severe ridge resorption. Next, what we can check is the parallelism between the ridges. Paralleling and a 5-degree opening in the posteriors is acceptable as suggested by Sears. However, this rule is not acceptable in patients showing ridge resorption. Also, there are instances when the patient loses teeth at different periods of time when parallelism may not be present. Measurement of former dentures also act as a guide to determine the vertical dimension. A Bowley gauge can be used to make the measurement. The measurements obtained from the dentures can be correlated with the facial measurements. Any increase or decrease in the measurement desired can be made in the new dentures. The next method is the use of pre-extraction records. This data reveals the progressive changes which occur when the patient's teeth are extracted. The pre-extraction records provide information about the occlusal vertical dimension, anterior-posterior angle of occlusal plane, position and inclination of maxillary central incisors, horizontal and vertical overlap of each tooth, and length and width of teeth. The profile radiographs proved to be useful records. Lateral skull radiographs before and after tooth extraction are compared. However, this method increases the risk of exposure to X-rays. Next method is the use of profile photographs. Profile photographs with teeth in maximum occlusion are useful while recording the vertical dimension of occlusion. The photographs are enlarged to life size and the measurements using the anatomic landmarks on the photograph are compared with the measurements using the anatomic landmarks on the face. However, the disadvantage of this method is the inaccuracies resulting from photo enlargements. Also, profile silhouettes can be used. Lead wire adaptation along the midline helps preparing a cardboard cutout which is preserved after extraction of teeth. It is then positioned on the face after the vertical dimension has been established and or when the artificial teeth are tried in. Mounted casts of teeth in occlusion also act as a guide. Casts of teeth in occlusion mounted on the articulator help us know the distance between the ridges before the teeth have been extracted. Hence, it acts as a guide to determine the vertical dimension of occlusion. This method is especially useful in patients whose ridges are not resolved much after tooth extraction. The next method is the use of resin face masks. Acrylic resin face masks are made before the extraction. Later, after the tooth extraction, when the patient is edentulous, the mask is fitted on the face to see whether the vertical dimension has been restored correctly. However, extensive practice and great deal of time is required to follow this method. Facial measurements can also be used to determine the vertical dimension. For example, the distance between the pupils and the corner of the mouth is equal to the distance between the tip of the nose and the chin. This is known as the Willys guide. These facial measurements prove useful in determining the vertical dimension at rest. There is another concept known as the equal thirds of the face. This concept states that the face can be divided into three equal parts: the forehead, the nose and the lips, and the chin. This method also proves useful to determine the vertical dimension. Different instruments like Willys gauge or calipers can be used to make these measurements. The other category of methods that can be used include the use of physiological methods. The determination of the vertical dimension and occlusion using the vertical dimension at rest and interocclusal rest space is also used many times. To determine the vertical dimension at rest, the patient should be asked to relax with trunk and head unsupported. After insertion of occlusal rim, the patient should be asked to swallow and let the jaws relax. The lips are then parted to see how much space is present between the rims. The interocclusal distance should be 2 to 4 millimeters. If the occlusal distance is more than 4 millimeters, then occlusal vertical dimension is too small. If the occlusal distance is less than 2 millimeters, then occlusal vertical dimension is too great. Occlusal rims are adjusted until adequate interocular space is obtained and patient comfort, phonetic and aesthetic considerations are satisfactory. The next factor to be considered is the phonetics. The occlusal rims should be placed intraorally. Then the patient should be asked to pronounce different words. A correct vertical dimension allows clear pronunciation and acts as a guide to determine the correct vertical. For example, the patient is asked to make ch, s and j sounds. Normally, mandibular teeth move forward to a position nearly directly under and almost touching the upper incisors. If the anterior part of the rims touch when these sounds are made, the vertical dimension is too great. The vertical needs to be reduced in this case. The next method is the use of closest speaking space to record the correct vertical dimension. This method measures the vertical dimension when the mandible and muscles involved are in physiologic function of speech. The occlusal rims are placed in the mouth and the height is adjusted until a minimum of 2 mm space exists when the patient pronounces the letter S. Closest speaking space may vary between 0 to 10 mm. However, the disadvantage with this method is that patients having 8 to 10 mm as the closest speaking space will require another method to determine the vertical dimension. The next method includes the use of F and V sounds. When the patient is asked to make F and V sounds, the edge of the maxillo-occlusal rim should touch the vermilion border of the lower lip. Next is B, P and M sounds. When the patient is asked to make B, P and M sounds, the vertical dimension should be such that the upper and lower lips should meet each other. An inability for the lips to meet indicates an increased vertical dimension. The next method involves the correct development of facial aesthetics. Labial surface of the occlusal rims should be contoured to replace or restore the tissue support provided by the natural structures. If lips are not properly supported anteriorly, tendency to increase the vertical dimension is great, which may lead to an increased lower facial height. When the vertical dimension is increased, the skin of the lips appears stretched compared to the skin over other parts of the face. The skin appears more flaccid with a decreased vertical dimension. Next method is the swallowing threshold method. It is observed that teeth come together with very light contact at the beginning of the swallowing cycle. The highest point of contact between the teeth is the vertical dimension of occlusion. This technique involves the building of cones of wax on the lower denture base in such a way that they contact the upper occlusal rims when the jaws are opened too wide. The flow of saliva in the patient's mouth is increased by food, such as the pieces of candy. Repeated action of swallowing the saliva will gradually reduce the height of the wax cones to allow the mandible to reach the level of vertical dimension of occlusion. Length of the time to complete this method and the relative softness of the cones will affect the results. The next method is through tactile sense of the patient. The perceived comfort of the patient enables us to know the vertical dimension. In this method, we ask the patient to open his mouth wide till he feels strain in the muscles. When the opening becomes uncomfortable, ask the patient to slowly close his jaws till he or she reaches a comfortable relaxed position. This relaxed position helps us to record the vertical dimension of rest. The next method of tactile sense includes the use of neuromuscular perception. This method depends on patient's perception of different heights. A central bearing plate is attached to accurately adapt to one record base and the center bearing screw to the opposing record base. The center bearing screw is adjusted beyond the rest position. Screw is then lowered half turn. Patient has to feel and tell if there is overclosure. Pin is again raised till excess opening is seen. Appropriate vertical dimension is judged by the patient according to his comfort. However, this method cannot be used in patients having poor neuromuscular control. The next method includes the use of Booth's biometer. Booth suggested that the maximum biting force in an individual is registered at vertical dimension at rest. In this method, the biometer is attached to an accurately adapted mandibular base. Then the metal plate is attached to the vault of the maxillary record base. The gauge present indicates the pounds of pressure generated during closure at different degrees of closure. When the maximum power point is determined, lock the set nut. Then make plaster registration and mount the cast on the articulator. This record provides us with the vertical dimension at rest. When 2 mm is subtracted from it, we will get the vertical dimension of occlusion. The next is the most commonly used Niswonger's method. In this method, 2 marks are made, one on the tip of the nose and other on the chin. The patient is told to speak words ending with the letter M. The distance between the 2 marks is then measured. Then the occlusal rims are placed intraorally and then the distance is measured between the tips of the nose and the chin when the rims are touching occlusally. If the difference between these 2 marks is 2 to 4 mm, then it means that the vertical dimension has been correctly recorded. Like for example, if the VDR comes to be 72 mm and the VDO comes to be 69 mm, then the difference between the two, that is a freeway space, is 3 mm, that is between 2 to 4 mm. So this vertical dimension is correct. Now let's revise what we have learned till now about jaw relation record by solving some multiple choice questions. Question 1. The closest speaking space was suggested by option A, Pound, option B, McGrain, option C, Niswonger, option D, Silverman. Question 2. Increased vertical dimension of occlusion results in option A, strained face appearance, option B, trauma to underlying tissues, option C, clicking of teeth, option D, all of the above. Question 3. Freeway space is defined as option A, vertical dimension at rest minus vertical dimension at occlusion. Option B, vertical dimension at occlusion plus vertical dimension at rest. Option C, vertical dimension at rest. And option D, vertical dimension at occlusion minus vertical dimension at rest. Take your time to answer these questions. You can later verify your answers by checking the description section below. Please like, comment and subscribe to this channel to learn about various dental topics. You can also ask us any other questions or give suggestions in the comment section below.